The only way to be able to bear that legal liability pressure was to be the person who knows the most in the room. I always separate legislation from regulation. Those are two different things. And legislation is the hard line. Regulation is the most softer line. And so I knew legislation, I knew regulation, I knew expectations, because it's not because there's a regulation that you're expected to do things in a certain way. And people usually just have all of those three together. They're like, oh, but you should be doing that. I'm like, no, that's expectation. That's not legislation, that's not regulation, that's expectation.
The chief medical officer role at a health tech startup is arguably one of the most important jobs. My guest today knows a thing or two about being one. He knows a thing or two about hiring one, training lots of them, hiring lots of them. His name is Benjamin, and he's got a fascinating background. He's done many, actually, humanitarian missions for a start to the likes of India and Syria. He's an NHS obs and gynae consultant, an entrepreneur and co-founder of Leva Clinic, and a career chief medical officer. So he now advises companies on how to get a chief medical officer, how to get the best one for them. Talks a lot about the varying skill sets of chief medical officers. They come in various shapes and sizes with various skill sets. So different people become a chief medical officer with different skills. Different companies require chief medical officers with different skills. He talks all about this. And talks about how to become one. If you are a medic, if you are a budding chief medical officer, if you want to take that role into a startup, you might not even know what it means. You're going to learn that on this podcast. You want to learn how to get there, you're going to learn it on this one. And you're going to learn loads about how Benjamin got to where he is too. So hope you enjoy this one. So Benjamin, welcome to the Healthtech Podcast. How you doing, mate? Very
well, very well. Thank you for having me. It's nice to see you, James.
Yeah, you're very welcome. It's about time I had you on. We've both been in the health tech space for a heck of a long time. We always see each other at events. We've bumped into each other many a time. We've put the world to rights many a time in many an event space. So it's about time that we had all those conversations on here to be a little bit accountable for it, I guess. Like, we have our thoughts, we have our beliefs.
Exactly. Someone can finally hear what we're talking about.
Absolutely. And someone can tell us how wrong or right we are, which is ideal. So, Benjamin, you've done so much in the space. Obviously, an NHS consultant, you held on to medicine and you still hold on to medicine to this day. You practice clinically, but you are and have been a significant player in the health tech space. You've founded Leva Clinic. You've been a consultant and advisor to many a startup. You've built this portfolio career. You remain, as I say, a consultant in the NHS even to this day, and you've managed to balance both. And you have, I think, what a lot of people listening will consider like their dream career, like calling a spade, like being able to mix the clinical with the health tech, making impact across the space. You've got variety. You advise fertility companies, AI companies, insurance companies. There's lots going on for you. And so I think it'd be really useful for people to get a flavor as to, I guess, how this happened. Your journey obviously starts with you as a junior doctor like the rest of us, and it's turned into what this is now, this beautiful portfolio career working across health tech and still clinically. So I guess, mate, for the benefit of our listeners, start at the beginning and tell us your story.
Yeah, so I'm Benjamin, I'm French, as my accent will tell most of your listeners. I'm a doctor, trained in France, became a consultant in the French national health system, and then moved to the UK and had to rebuild my career from scratch when I arrived in the UK about 10 years ago. And that I think that's what a lot of people ask me about, is like, how do you build a career like that? As you said, a portfolio career over 10 years. When I introduce myself, I have the elevator pitch, and usually I just split it in 4. And it's funny because I've used that introduction in all of my settings, whether it's clinical, academic, entrepreneurship, or others. I've used that same split in 4 introduction. It works really well. So usually I say, I'm a clinician. I see patients. My clinical specialty is obstetrics and gynecology. I'm specialized in high-risk pregnancy, and I've delivered more than 1,500 babies to this day. And that usually the first question I get is, how many Benjamins have I delivered? And it's barely 10. So not a lot of babies named Benjamin. But that's for the clinical part. I have an academic part. I was a lecturer at Paris South University. I've published peer review journals in lots of different papers. I've done research, organized research. I taught at the university. I still teach to this day on a weekly basis, and it's something that was really, really, really awesome. That's an also life. It requires a lot of dedication, and it's something that I've really took a step back on from when I started doing much more health tech. So about 8, 10, 9 years ago. I'm an entrepreneur. As you know, and I think we're going to go much more into the details on that front. And I've done a lot of humanitarian missions. I've delivered babies on 3 different continents. I've worked in Syria during the war. I've worked in India, in the slums of India. I've been to different refugee camps across Europe, including the jungle of Calais. And I've tried to help women all over the globe when they didn't have the minimum requirements of support by being there. And that's also a really, really interesting, more than interesting, it's a really fulfilling segment of my life. Now that I have children, my wife is completely against me going to war-torn zones to deliver babies. Because when we started dating, I went to Syria, and she could hear the shelling and the bombing on the front line behind when I talked to her on the phone. And she was like, no, like, you're not doing that anymore. And but I haven't done humanitarian medicine in maybe, what has it been? It's been more than 10 years now. But I still bring that experience with me in any startups I work with, because there's something about scrappiness, about you don't have what you should be able to have normally. You don't have what you need, but you're going to make it work nevertheless. And that's a really interesting skill that I use in a lot of different aspects that we can come back to that. So that's usually my little 4 quadrants of my life. That's how I introduce myself.
That's beautiful. To put this, I guess, in an order for people, what you obviously start with, I'm a clinician, right? And of course, you started as a junior doctor in Paris. What came first for you? How did you plot the humanitarian stuff, the academic stuff, then working with startups? What order did this all appear in?
I think I followed my gut most of the time. There wasn't a really clear, defined plan. I was a doctor. I've always wanted to be a doctor since I was very, very small. And very early on in my career, I was like, okay, gynecology and obstetrics is for me. Women's health is, to me, one of the most incredible aspects of healthcare. I feel that I have a deep connection with my patients, and that's the kind of doctor that I am. But while I was going through training, when I was a junior doctor, the hours are excruciating. The pressure is immense, and I needed a way to get out of my head. And to me, it has been entrepreneurship. I was a very young junior doctor. I was like, clearly the system is wonderful, but this system is antiquated. We need innovation, and I'm going to find groups of fellow-minded people, and we're going to talk about it. And that's what I did. I just created one of the first community in Paris for health tech at the time where the ecosystem didn't exist. There was no health tech dedicated VC in Europe. There was no health tech dedicated accelerator. There was no formalized community. And so it was just a bunch of junior doctors in Paris talking about, oh, I saw that. Maybe we could use it this way. And then just testing reality and just having fun. And it led to me building events. And I created equivalents of hackathons. Everybody knows about hackathons. And everybody's like, oh, like we've organized a hackathon. But hackathon works really well for tech startup. In healthcare startup, it's completely irrelevant. I think a hackathon is all about the product. And in health tech, what's really, really difficult is the regulation, the business model. How are you going to fund it? How are you going to sell it to? Who are you going to sell it to? What are the the obstacles on your path to be able to deliver that product and to be able to sell it to someone. And so what I did is I organized startup weekends where I added the regulatory segment into it. Usually startup weekends, you have to present your business model, your acquisition strategy and all of that, but you don't have to look at the regulation strategy. And so I created a new format of startup weekend where you also have a fifth segment, which is all about regulation. And so I organized, and that's how I got into my first events. And I did lots of startup events across the world, including one, which is now very relevant, where I went to Bethlehem's in Israel, and we had the first startup weekends dedicated, which had 50% Palestinians and 50% Israelis in it. So that was a really, really nice startup event. And I just built my community, built my network. A lot of the companies that won through the startup events that I organized, I've kept trying to provide them with support, advice, and it has led to me becoming a freelance consultant in the long run. But it was years of free support, free advice, and conversations with people that I like across the globe, and being like, oh, I haven't talked to you in 6 months. Where are you? What's happening? Oh, you thought of this? Did you think of that? That kind of conversation, which is, of course, you would never make a friend pay for that, but over a long time, it has led to a career as a freelance consultant in health tech.
That's really nice. It's a very organic journey, that, through following your interests, which I love as a concept. And you described it, following your gut and following, what you think is right, but broadly just actually doing what you're interested in and actually really making an effort to add value. Like the startup weekends, the communities, and I guess going against the grain and going, this thing doesn't exist, it may or may not work, I'm going to try it. That's such an important concept for actual innovation. I think it's very easy for people to dip into an innovation community that already exists and then to talk about other ways to innovate. To actually set up communities is really hard. It's actually the most important step, because we all stand on the shoulders of giants, and actually doing the first thing, even if it's not perfect, it has the most tall grass that you need to swashbuckle your way through. It has the most obstacles. It has that feeling of wading through treacle quite a lot of time, but there is a lot of value at the end of it, of course, because then by owning the community, you're in a really significantly, powerful place to actually make your impact and all the rest of it. So I think that's really nice. It would be remiss of me not to actually go back though and talk about essentially this kind of war zone medicine that you were doing, just because I think it's a really, it's a really pertinent time to be talking about it, obviously because of the what's going on in Gaza and Israel, Palestine, etc. And we know that there are so many of these war zone areas where this sort of Médecins Sans Frontières work will be just so important. What is your experience of that? You talked about the shelling and the actual medicine that you were doing. I think it strikes me as important in your journey because you talked about it becoming relevant to then startups later. You talked about this feeling of the odds being against you and you just having to get things done, and that feeling becoming familiar later in startups. But I don't want to reduce this to just an experience that helped you become a startup consultant. It's obviously far more than that. What it did for your purpose, what it did for your ability to practice medicine, what it did for possibly your opinions of how health tech can fit into a highly unregulated area, because frankly, who cares when you're just trying to save lives? So with all that in mind, like, I don't know, tell us a couple of stories from that period or what your broad feelings are as you think back on that period.
It's interesting to talk about regulation, what you just said, because very few people actually think about that aspect of humanitarian medicine. Yeah, and you're right. A lot of people say, well, you're over there and you're just there to save lives. So really, all of the regulation doesn't really matter. And I will say regulation is not implemented, but actually that's not really true. When I take the case of Syria, it was the Zaatari refugee camp, which is now the biggest refugee camp in the world. Almost 300,000 people living there. And it's highly regulated. You've got the High Council for Refugees from the UN that is there. And as a French NGO, we coordinated our care with the Department of Health from Jordan, with the UNHCR. You'd have to monitor for epidemics. You have to monitor for a lot of things. And actually, if you arrive and you just want to help, but you don't coordinate, you don't have clear governance, you don't have clear regulations, it's an incredible mess. I remember that very vividly. There's this story. I arrive at a minor camp in the jungle of Calais, where I had a couple of patients to see. They were pregnant. I had said, okay, I'll come back next week. We'll do a quick scan, take a look at how the baby's doing. And I show up and everybody's in mourning. I'm like, what happened? One of the, you don't want to call them houses, one of the small things that were organically built that was hosting one of the family had collapsed during the weekend and the family had died. And it was not my patient, but it was a family that they knew. And I'm like, but how is that possible? And then what had happened is some people, very well intended, who were not builders, but had some leftover materials from their own little projects at home, came into the jungle and built a makeshift protection /house. You don't really know what it was. It was 4 walls and a roof and a door. Okay. But they didn't have the experience. They didn't communicate with anyone that they had done this. And they're like, you go there and you say, oh, I'm just going to help. But actually that house was completely unsafe. The grounds is a swamp. So it actually went down into the swamp, ended up collapsing during the night on the family. And so, and I have many discussions like that, which is that actually, even in an area where you think that you're reaching a greater purpose, sticking to very clear regulation, to governance and clinical governance in health tech is usually one of the Achilles heels of the startup is something that is highly important, because you want to build on strong foundations, literally. And otherwise, even if you think that you're aiming for a greater good, without coordination, without regulation, without governance, what you're going to create is not going to be sustainable. And that's why even in the case of the middle of the desert in Syria, we had patient records. We communicate with all the other NGOs. We just agree who's going to be the main link for that patient and that family. And if I do something for one of the ladies, I will send a letter to the Italian NGO who has been agreed to be the link for that family. It's going to be a 5-minute conversation with a guy in passing, or it's going to be an email, but it's going to be like, oh, by the way, I saw the mother. She's now that many weeks. Everything's going well. Tell me if they can't find any heat at night, if we're really concerned about temperature, because, for example, when you're pregnant, you have a high risk of DVT. And when your body temperature drops while you sleep, you're already inactive. And if your body temperature, you increase your risk of DVT, there's a high risk of PE. So if you're in the middle of the desert and during the day, it's super hot. So walls are paper thin, they live in tent. But during the night, it gets really cold. You have patients that develop DVT and PE during the night. And I'm like, okay, if they don't have any source of heat, just come back to me and I'll try to see whether or not I give her, pressure stockings, or whether we discuss something, because we don't want an adverse event to happen. And so it's that's one of the things that I keep telling to a lot of junior doctors, to a lot of startups, is like, yeah, the NHS is very painful because of all the regulation, all of the governance, all of that, but it has a purpose, and you see it in every context.
That's so interesting. What you're talking about there is order versus chaos, aren't you, as well? And regulation being something that can instill order. You're talking about process. It's really interesting to me, though, because I do wonder when that goes too far. And actually, with so much of the workforce conversation being around like the over-processed nature, the centralization of trauma and all the rest of it and everything that comes along with that, it's interesting to me. I know this isn't strictly health tech, but I have a question, which is that, so I did a neonates job as an F2 at St. Peter's in Chertsey. And I can remember it was a really strange time in my life because I struggled after let's just say, after a significant event on NICU. It was, I mean, sort of a negative outcome clinical event. It would be very difficult for me to, I guess, behave normally in my normal life, because then to go home and to be expected to care that the rubbish wasn't taken out, or to be expected to care that I was 10 minutes late to this thing, or that this thing was given in, I just sort of, I started to it really affected my perception of normal reality and what mattered and what didn't. So in my personal life, I found that actually incredibly difficult. And actually, I would say a significant relationship at the time, took an irreversibly bad hit at the time and changed the course of my life in various ways. But actually, professionally, it was also the case, because I went from that job into a different job where I struggled with the reality of hold on a minute, there's all of this going wrong over there, which is under-resourced, and we are over-resourcing elective orthopedics for things that don't actually matter. And I was I really and again, that was my thinking at the time. I'm not saying it didn't matter. Of course it did to those people and those individuals. That is their 100% reality. And I'm not saying that I was right in this thinking. But what I'm saying is having had an extreme version of clinical reality presented to me, it expanded my consciousness to a point of, well, this is the stuff that actually matters. How am I now expected to do all of this? And that was personal and professional. So I'm interested in what you've just said there about, and applying that to regulation even of well, is it not just incredibly frustrating then that all of this stuff is just over-regulated? Is it not incredibly frustrating that we do some things clinically and so much resource is deployed over here when in your heart of hearts it can be deployed over there, because you're seeing Israel-Palestine going on right now, and you know that all of this energy that we're spending on revalidation and getting things ticked off and all of this ridiculous wasted energy could be spent somewhere better. I don't know, I'm perhaps putting words in your mouth, but that was my experience. I'm interested in your perception of that.
So I agree with you on many points. I think what you said about the weight of clinical life on the mind is one of the reasons I actually got into entrepreneurship, because I felt like this was my mind holiday. I was on labor ward and we had patients bleeding. We had lots of complications. It was very heavy. It was a lot of hours. It was the French system at the time. And at the time there was no European directive. It was 80 to 100 hours a week at the hospital. It was all of the stories of the old consultants say is what I had. And it was really difficult. And then when you're out, I needed an escape. But I was still very tied to that purpose, helping patients at a greater scale, always over and over again. And talking about health tech, improving the system was something that helped me, provided me with that buffer, that mental and emotional buffer, which you said is really required when you're a clinician. And at the same time, I felt I could help, and I could scale also. I was really obsessed with scaling because now I've delivered more than 1,500 babies. But at the time, I was still counting single, then double digits deliveries and all of that. And I don't keep at the time I had my little book of babies, and then now I don't have my little book anymore. I know vaguely where I am, and I'm somewhere at 1,600, and that is, but it's just after being a gynecologist for 20 years. And I just felt that scaling was something that I had thirst for at the time as a junior doctor. And so I was like, okay, I'm going to build systems that can scale exponentially. And for example, one of the clinical algorithms that I designed for a company as a freelance consultant, and that was 10 years ago, has been seen and has done asynchronous consultations for 1.4 million patients by now. And I'm like, it was a completely different amount of scale for me. And for me, that was the thing. I was like, there is so much help needed across the world in the French national health system, in the NHS, but across the world. And I felt like I wanted to do more. And to me, Healthtech was the right way to do that. And that's interesting, because it's really that at the time there was no asynchronous consultations, and the whole idea on which all of the companies like Newman and Manual and all of that are based now didn't exist and was very frowned upon at the time. And I was like, no, like we can do something and we can help. There are safeguardings to put in place. There are governance to put in place, but we can do stuff. And that particular algorithm, I'm like, now when I look back at it, I'm like, it has taken its life on its own via a company which I'm not involved with anymore, but it's still a part of the patients I've touched and helped. And to me, it was my personal answer, because I knew I couldn't solve all the problems all the time. And as you say, you can feel frustrated, but you can't solve all the problems all the time. And I knew that for me, it was okay. Let's try to do what I can do on labor ward, where I know I'm good and I can help and support my patients. Let's try to push the entire medical industry towards a more technology advanced and efficient state. And let's try to slowly but surely get things into a better place.
I love that, which is essentially just use it for motivation, and use it for motivation to do things that are applicable globally, which is where obviously the health tech comes in. You then obviously go on to do lots of different projects, freelance consultancy projects. It leads you into an entrepreneurship role, a founder role, co-founder role at Leva Clinic, chief medical officer roles. Talk us through that part of the journey, the entrepreneurship part, getting to a point where you then found your own company. Tell us that bit.
I always had the itch. I think if you don't have the entrepreneurial itch and you get into entrepreneurship to become a millionaire, that's the wrong thing. The path is painful. It's way riskier than anybody can think about it. So you really have to have that itch. And I had that itch for a long time. A long time. And my father's an entrepreneur. My brother's an entrepreneur. Like there is a family sense of innovation entrepreneurship, which is very, very strong. And so the thing is, the infrastructure didn't exist. It was inconceivable at the time in France to leave a career without your diploma, without being a consultant. At the time, if you got out of training, you just lost most of it. It was not possible. So when I had some moments of despair as a junior doctor, I was like, okay, I'm going to become a consultant, and then I'm going to take a year off, and I'm going to do something. But let's finish that first. Which now junior doctors can very easily, because all of that infrastructure exists. You can tell your training, your dean, like, okay, I'll be out of training for 2 years. Just keep my number, and I'll pick it up. Like at the time, it didn't exist. So really, I think if I had been in a place where there was infrastructure around, I would have gone into entrepreneurship earlier, which is a double-edged sword.
It is.
Like we can talk about what it is to be a CMO when you're a med student, or being a CMO when you're a junior doctor, and the difference with being a CMO when you're a consultant, yes, or later. It's a double-edged sword. So I had to be a consultant. I had to have a position as a consultant before I could put all of that behind me. And then I met my wonderful wife, who's American, decided that the UK was better for us than France, moved to the UK, and had to start everything all over again. Had to rebuild the network, has to start all of that. So I lucky enough that some of my companies were across Europe. So of my portfolio companies were across Europe. So it was easy for me to continue to rely on a European network, but I didn't have much network in the UK. And so I did the exact same thing, organized a community, organized the first startup weekend in the NHS, built friends, networks, and started over, and then did some consultancy work in the UK as well. And then one day I was like, okay, I'm ready. I know what I want to do. I have the experience. I have the network. I have the capacity. Let's do it. And that's when I created Leva Clinic. And I created Leva Clinic because everything came together at the right time, at the right place, in the right moment. Like, chronic pain is very close to my heart because my mother suffered from chronic pain all of her life, or a major segment of her life, all of the life that I know from her. I knew you in order to create and have a very lean digital healthcare provider, you need to be able to hold all of the licenses in-house. So you need to have someone who can be a CQC registered manager, a nominated individual, someone who can be a data protection officer for the ICO, someone who can be a Caldecott guardian, someone who can be all of those things. And over the course of all of my years, I have had built the experience and the accreditation to be all of those things. I had the right diploma, the right experience, and I held all of the 7 licenses of Leva Clinic on my shoulders. All of those title and positions that are required for you to be able to provide care. You have to have someone who's responsible for controlled drugs, because it's one of the rare companies that is actually prescribing controlled drugs online. That's another kettle of fish altogether with regards to clinical governance and all of that. Like, there's lots and lots of things that are required. And I knew at the time that I had, from my experience, from helping other startups, and then from also learning from their mistake, I was like, okay, now everything is aligned. I can do that. And that's when I created Leva.
That's really interesting. So just out of interest, well, actually, let's start at the beginning. So do you want to just explain exactly what Leva Clinic is, what it does, who it does it for? And then my question after that is, with those 7 titles over your head, I'm interested in what your actual risk is there. Because again, I think those are all 7 of those are roles which a lot of people listening might go into a company and have. But I know that people that have done medicine, myself included, always think in their minds, like, what's my risk here? Like, what documentation do I need to do? What am I protecting myself against? Am I going to read this in court one day? If so, what's going to be the sentencing that I'm going to be potentially up for? Like, you know, these are all the thoughts that, of course, go through our minds. So yeah, run through Leva Clinic and then, talk about some of those roles and actually some of the risks, because I'm interested in that.
So Leva Clinic is a digital healthcare provider that provides services to patients with chronic pain. So for your listeners that are not aware of how to treat chronic pain is a really, really complicated condition. The whole idea is once the anatomic substrate of the pain has disappeared, the pain persists because of negative neurological feedback loop within the peripheral nervous system and the central nervous system. And the best example is phantom limb pain. There's no hand anymore, no feet anymore. And yes, you feel that excruciating pain in your feet or your hand. And it has tons and tons of different origins, type 2 diabetes or any type of diabetes, like stroke, like there's lots. It's a highly complex condition. And treatment doesn't work. What we think as treatment doesn't work, because the only way to treat it, you need to have a biopsychosocial model of care. You need to treat the body, treat the mind, enhance that with education and pharmacological treatment. And that's the only way to do it. Because if you look at all of the opioid epidemic is a good example. If you only use medication and you don't do all the rest, then it just doesn't work. You're going to get a 20% improvement. You're never going to get a 60% improvement. Right? My mom was the perfect example. She was taking 280 milligrams of morphine a day, which I would OD on it. Oh yeah. It just didn't work. And it just doesn't work. So you have to do all of those things. And you have to have, it's very costful, and you need to have very high efficiency if you want to do it in a cost efficient manner. And so at Leva Clinic, we have everything under one roof. We have psychology with clinical psychologists who can do counseling. We can do CBT, ACT, all forms of psychology that are required. We have physiotherapy. And so we do video over IP physiotherapy sessions. One of the main benefits is that you're in your own house and you can do all the exercises overseen by that physiotherapist, but in the context of where you actually do them. And so for our patients that say, I can't attend my rosebuds because I can't kneel anymore because my knee are too painful, you can go in the garden, put the camera in the garden, put your phone in the garden and say, okay, show me what you're doing. And then we can help you locally. We can tell you, okay, you need a range of motion, which is at least 90 degrees to be able to do that. So we know what is our goal and all of that. So we do as I said, psychotherapy, physiotherapy, we do nursing, we do education, we do some segments of social care, and we do pharmacological management. Everything under one roof. And everything has to be under one roof because the way the NHS provides care for patients with chronic pain is completely fragmented and it doesn't work. It just doesn't work. There's few high specialty units in big university hospitals that have everything under one roof, but it will take you 10 years before you're referred to that specialty units because your GP will try a little bit of physio and then a little bit of pharmaco and then a little bit of this, a little bit of that, but you need to have everything under one roof. And what's really interesting about that is I can give you an example. I'm thinking about a patient, 60 years old, rheumatoid arthritis, that wanted to take care of her grandchildren. And she has too many mobility impairment, too many pains to be able to do that and be left alone with her grandchildren. But actually, if her children are there, then she's not really supporting her children, and she can't take care of her grandchildren alone. So she's like, okay, for the next 3 months, we're going to work on you being able to do those activities, and we're going to help you. And the physiotherapist says, okay, we need to increase range of motion in those joints to be able to do that activity. So I'm going to design a physiotherapy program, which means that she's going to be in way more pain during those 2 weeks where I'm going to increase the range of motion. And then he says that to the consultant, said, okay, so during those weeks, I'm going to add some codeine on top, and she's going to take the codeine half an hour before the physiotherapy.
Yeah.
And then the nurse says, oh, okay, so what we can do is I can communicate also with her job and make sure that her occupational health, make sure that during those weeks, she's not doing that other activity of her job plan, because during those weeks, she's going to have a lot of pain in her knees and her hips. And that's where the psychosocial model of care actually works, because you have everything under one roof. Yes. And so you needed that form of care. And that's a digital provider that does not exist or did not exist in Europe at the time. So I was like, okay, we're going to do that. We're going to do digital therapeutics. We're going to do digital education. We're going to do social care. We're going to liaise with social services. We're going to liaise with occupational health. We're going to do all of that. We're going to liaise with the GP. We're going to do everything under one roof, and we're going to help our patients. And we do the pharmacological management. At the time, what's really interesting about the pharmacological management is there was pretty much the CQC has said there's not going to be any controlled drug prescription in the UK by online companies. What happened is, under the European prescription umbrella, there had been some pill mills in Eastern Europe that had prescribed a lot of opioids to a lot of patients in the UK. You know, those kind of pill mills where like it's a phone call, 5-minute conversation with a doctor in Eastern Europe. You pay £20 and you receive a prescription for your morphine, which is most likely more used by addicts than anything else. And so the CQC was like, okay, we don't understand. We don't know how it works. Control drugs online. We will just blanketly say no. And so I arrive in this situation and I'm like, okay, we can't care for our patients if we can't prescribe controlled drugs. We have to be able to do that. So we had to design the clinical governance to be able, and the clinical assurance, to be able to reassure the CQC that we were doing that correctly and that we were liaising with the GP, that we were making sure that there was no other prescribers of controlled drug, or if there was other prescribers of controlled drugs, we connected with them. Like we had to create all of that infrastructure, which led to our license, which was one of the very few licenses to prescribe controlled drug online, because it is highly, highly complex to do. So without realizing, I had the most complex healthcare pathway in front of me. And I was like, okay, I'm going to tackle that face on. I know what I'm going to do. And we succeeded. So it was an incredible adventure.
That is incredible. And actually that's the entrepreneur in you that goes, oh, there's a blanket rule that says no, that can be changed. And that's sort of like it's almost like a pathological belief that everything's negotiable. But actually it's not, because it was negotiable, it was changeable. And actually you've put yourself in their shoes and gone, well, if I was the CQC here, of course I've given a blanket rule, but of course I'm going to listen to reason. And actually, if I present that reason in such a way, I might be able to get them to change their minds. And many people will have looked at that and just gone, well, this isn't a goer because there's a blanket no. I think that's really interesting. There's obviously that's a huge grey area of which of those problems should you go after? You know, the assumed beliefs, the blanket assumptions that already exist across the system that are preventing innovation in so many ways. I wonder how many of them are actually negotiable. And I guess that's for the entrepreneurs themselves to figure out. Yeah,
exactly. And it's all about granularity, which is that if you talk
Yes.
to someone at the CQC, it's most likely a rule that they didn't put in place because they rotate and it's been a rule for a certain amount of time, and they don't have the level of granularity to see where the risk lies. So they put a blanket no. Whereas if you come to them, you show them with very high granularity where are all the pain points, how you're going to mitigate risk at each of those pain points, and you take them on a journey of clinical governance. I know I talk a lot about clinical governance, but it's the only way you're actually doing things safely. If you take them on a journey of clinical governance, you can sway them. And to the point that at Leva Clinic, we included cannabinoid medicine in our pharmacological offering. And so we are one of the very few companies that are prescribing cannabinoids for treatment of care of our patients. And you're at the highest level of risk because it's an unlicensed controlled drug. It's not just a controlled drug. So you're at the level where every pharmacy is just saying no, like I won't touch it. Every hospital say I won't touch it. Every company says I won't touch it. But the data behind the care of patients with chronic pain on cannabinoid is very solid.
Yeah.
And it cannot be overlooked. And so we had to include it in our offering, and we managed to do it. And we had our CQC inspection, and we had one of the best rating of the entire industry. We had outstanding and well led. We had good overall. Like our CQC inspector was really, really happy. He was like, "Oh, I've never thought of that. Oh, you have that already in your policies, in your guidelines. Oh, I didn't think about that. Oh, that's great. You have it." Like just because the industry doesn't exist, because that kind of services doesn't exist. And they were like, "Oh, you already. Oh, I had that question. Oh, I can see it's here already. Oh, great. And I was like, that, yeah, it was really, really interesting to design all of that.
One thing I want to point out here is, so I was asked the question last week, which was, what do I need to learn to get into health tech? And my answer was almost literally anything apart from healthcare or technology, because that's not going to be your value in health tech. It's going to be the other thing that you learn. For me, it was management and finance. I learnt how the back end of a hospital works, and I learnt how the finance department of a hospital works. That was my value in health tech. For you, it's governance, clinical operations, regulation. That is your value in health tech. Frankly, everyone knows the healthcare, everyone knows the technology. That's not going to be your value in that industry, because what we have now is an industry. Your value came from knowing in incredible detail to a point where you're so confident you can design things and give other people confidence around these specific policies, these specific requirements, these specific and actually quite granular and messy operational things from your experience. That's your value in health tech, which is just, smacking me in the face now. But I think this leads us on nicely to the role of a chief medical officer. And actually the question that I asked before around like, what were your risks? Because as the chief medical officer, the definition of you as chief medical officer here is probably the highest definition that you're going to get. It's called a COT guardian. It's this, it's that, it was all of those different roles controlled, like medicines. Like you were literally the overseer and the responsible individual for all of those different elements, which is, I suppose, the chief medical officer role. Legally responsible, correct. Which I suppose is the farthest reaching definition of chief medical officer, but there are many definitions. In this definition, though, which I would say is sort of like the top, I guess, or the where you have the most responsibility, Like when you go to work every day with all of those different titles above your head, yeah, what were you at risk of? And yeah, how does one get to a point where they feel completely okay with all of those things? Because I can imagine any medics listening that have a chief medical officer in their sort of eyesight of as to what they want might be thinking like, Christ, I don't want to be responsible for all of that. Like, my goodness. Or perhaps you can explain to them why they do.
Yeah. So it's, for me, the only way to be able to bear that liability pressure, legal liability pressure, was to be the person who knows the most in the room. As you said, it's like I was able to present the exact piece of law, guideline, the exact research article and be like,
right.
But if you say that it is unsafe to prescribe this, it's because you're thinking about the risk of drug abuse. Or are you talking about the risk of overdose? Because those are two different risks. I'm happy to have the conversation with regards to each individually, and then we can come back. And I'm like, oh, so the risk of overdose is this. This is the article. This is the guideline. This is the legal framework. I always separate legislation from regulation. Right. Those are two different things. And legislation is the hard line.
Yep.
Regulation is the most softer line. And regulation will change much faster than legislation will. And so I knew legislation, I knew regulation, I knew expectations, because it's not because there's a regulation that you're expected to do things in a certain way. And then people usually just have all of those three together. They're like, oh, but you should be doing that. I'm like, no, that's expectation. That's not legislation. That's not regulation. That's expectation. If that's expectation, it's completely negotiable. I'm like, the reason why you do that is because historically there was this pill mill in Eastern Europe.
Yeah.
But actually legislation says nothing about it. So then it's all about regulation. And regulation, the regulation is very unclear. And so the way for me was really to go into the highest level of details and make my own opinion. And having been an academic and being an academic, I can sit in front of big loads of paper and force myself to go through 200 pages of legislation. But I also have critical thinking to a point that I'm very confident in my own way of thinking. And I'm able to say, that makes sense. And sometimes there's nothing to be done. The CQC, MHRA, NICE is going to say, well, we disagree. And we are the ones that are responsible for implementation. And therefore you can't do anything. And sometimes you just come to the conclusion that you disagree on the interpretation of the legislation or the regulation or the literature. And that's fine. But at least you've taken them on a journey where you said, okay, this is expectation, not regulation. And that's something which is really important. And like at the time, getting into a highly complex clinical pathway, having the prescriptions of unlicensed controlled drug online, I have to say, of course, we benefited from the pandemic. I mean, it changed the vision of clinicians and patients and regulators alike on what can be done online. And it would be crazy to say it didn't, but we started the company before the pandemic, at a moment where really I was trying to go through a brick wall. It was difficult negotiation. And it's funny because it's both. At the same time, once we had our license, there was almost no one who was able to prescribe controlled drugs online. And then the pandemic arrives, and then the CQC says, well, every activity that is done face-to-face is allowed to be done online. You're like, oh, okay, so now, rather than having no competitors, I have everyone. That's much, but you still realize that no one would dare prescribe online.
I was going to say, you had a hell of a head start on them, Benjamin, honestly.
Exactly. So the only way to manage that pressure is really, as always, it's the difference between fear and anxiety. Anxiety is this blob where you're like, it's a little bit of everything. I'm just afraid that I'm going to get they're going to take my license away. I'm going to be put in jail for activities. Whereas if you actually start to separate every risk individually, like we had a risk register, huge risk register, and I had itemized all of the risks at every level. When we signed our first NHS contract, I was asked if my risk register had environmental risk, which is the one that I didn't have. So I actually had to add it and be like, okay, this is where we're carbon positive. This is where we're carbon negative. Wow. This is the environmental impact. But outside of environmental risk, I had mapped out absolutely everything and I had mitigated every risk and I felt confident enough. And then the rest, once you've set the direction, is just maintaining that rigor. And so I was at all the clinical meetings. I would make sure, like, teaching is repetition. And so I was like really making sure that all the doctors were doing things correctly. All of the staff, non-clinical staff, were doing things correctly. And it's all about maintaining. Once you've done all of that work before, and once it's very clear, I have had written, I think, 107 policies for our CQC application, when the average CQC application is around 30.
Wow.
And each of our policies were in average 10 pages. And I've talked with other companies who've started their CQC process and I've helped them. And in average, the other companies I support have like 30 policies with an average of 5 pages per policy. We were completely like, it was necessary for us.
Definitely. I think there's a lot of really interesting innovation and entrepreneurship lessons that are just applicable so broadly here. I absolutely love your framework of there's legislation, regulation, and then expectation. And that line gets softer as you go up that chain. I think that's a really interesting framework. I also think that what you've described around what it takes to be the all-encompassing chief medical officer, as you were in what you were talking about, requires essentially like you giving them all of these things that you mentioned are value. They're value to a company. And for individuals that are looking to become that chief medical officer, you don't have to do all of those things by all means. I'm sure some companies will have these functions spread across a few different people, but you're describing elements of real significant value. And that's what a chief medical officer is. It's not just the token medic that's just sat there in case a medical question gets asked. These are tangible bits of value that need to be added to add value onto a company that then delivers to shareholders. So like there's clear utility in what you've described as like there's certain things that you can learn. There's certain ways that you can become an expert. And I love that. That's real practical advice for people. And I also think it's interesting around like when we talk about innovation and we talk about entrepreneurship, these are exciting words that insinuate technology visions and futuristic visions and all these things. But everyone needs to create a moat behind them. All technology companies need to create a moat behind them. And I think in healthcare, very rarely is that a technological moat, i.e., what keeps the company defensible is how far-reaching the technology is. That's often not what the moat is. I actually think you've just described the absolute tedium of 107 policies that have been written, the knowledge of acquired over reading hundreds of pages of legislation, to not only know it, but to have an opinion on it and to form a critical opinion on where regulation could be changed or where legislation allows for regulation to be. Even in me saying this is like, I'm not legal in any way. Like this is areas that I do not know or understand. If I'm the founder of a company that now wants to hire someone that has value, I'm going to look to someone like you that goes, okay, yes, I've read 400 pages of legislation, and actually I know it from the clinical because I work on the ground floor, and this is my perceived value now. But I guess my point is that for health tech companies and for health tech entrepreneurs and for everybody listening that wants to be involved in health tech, like, when you're looking at the defensibility of a company, it can come from many places. And actually, a company's knowledge of exactly how regulation can be changed and affected. And that means they're going to be the only people that the CQC let through for a little while, at least. And you can get yourself a head start because you've done all that tedious yet hard yet incredibly useful and first time done work. Means that you're going to get a heck of a head start. You're actually going to make a change. You're actually going to then get that exciting technology in front of patients. But it's the tedium that sits behind that. And in part, that can fall to the role of a chief medical officer to actually do. And I say tedium, it's obviously interesting and exciting for a lot of people. I've got friends that are lawyers that find this stuff incredibly exciting. But yes,
yeah, exactly.
I think that's it's horses for courses when it comes to that. And obviously, when you are defining your own role as chief medical officer, pick what course fits you. But yeah, I think that's really interesting, man. But it brings me on to a question about I reckon no chief medical officer is created equally. I think people have different interests, people have different abilities, people are at various different seniorities in their career. You can have an F2 that's a chief medical officer of a very early stage idea that's protecting things and answering things from a medical perspective in the ideas phase or the early MVP phase. But then at your end, you can be Caldecott guardian and responsible for controlled drugs and writing real significant policies for the CQC. So how do you see the sort of breadth of chief medical officer roles, and what would your advice be for people that are kind of at varying stages of that journey themselves, looking to get on that ladder, or actually from the position of the C-suite of companies looking to hire a chief medical officer? How should they go about things? So how do you see that double-sided world?
So I have built a mental model of CMOs by interacting with a lot of them, by being one, by helping companies hire their CMO. So it's a really interesting question. And the way I see it is a matrix. And you have the level of seniority in the clinical area for the doctor, and then the different requirements of that the job spec of that CMO will require. And so you have people that will be med students and become CMOs. And a med student has built the knowledge of pathology. They've read the books, they understand the books, they understand the care, they know that lupus is affecting the kidney first and then other things. And they understand the pathology. And so if your company is focused on certain aspect of the pathology, great. If you can have CMOs that are junior doctors. So junior doctors understand the pathology and they've started treating patients. So they start to understand patient psyche, patient interaction, which the medical student doesn't have a clue of. And so they will understand better how to sell to patient, how to talk to patient, what are the expectations of patients with regard to their care. It's a completely different skill set. Then you have people that are consultants. And once you're consultants, you understand the pathology, you understand the patient, you understand the normality, which comes with understanding the patient, and you start to understand the politics. So you know that actually the funding for that segment of the pathway of care is done via NHS England, not the ICB. And that is important because it's funded by the department, because it depends from NHS England or the Department of Health, because it's secondary care only. Therefore, you need to organize your care that way in order to fulfill the requirements of that and that regulation. And you know that the person you're actually going to sell to is not going to be the ICB, is not going to be the hospital, is going to be NHS England, which is by far the most complicated part. So you start to understand that aspect, but you also understand all of the research, because that's the thing that is really lacking from junior doctors or medical students, that usually they understand the guideline, but they haven't read the underlying research. And it's again, what is expectation? What is regulation? What is legislation? And when you're a consultant, you've had the time, you've most likely in your field, in your narrow field of specialty, you've read the entire literature. And so it gives you a much different, and you understand also who the key opinion leaders are. Like, you know, all of those things, which is much less clear to more juniors. And finally, you have the CMO that was a doctor at any position and then went into consultancy went to McKinsey, or worked at a policy level, worked at the Department of Health, worked at the UN, the WHO. And that's the third, and that's the fourth level of CMOs. And those are really good for pure politics, pure negotiation, that's a completely different level of skill set, or pure strategy. But they will have the capacity to do all the other ones I've done. And of course, that model of what a CMO is will be broken by many exceptions. You will have people that have left the clinical life at a med student level, but have grown independently because they've done their MBA and then they've worked for McKinsey for 2 years and all of that. And so they will feel some of the aspects and some of others. But it's really interesting to see that a lot of CMOs don't know where their weaknesses lie because they don't see the whole scope of what CMOs can be. A lot of the C-suite board, when they're hiring the CMO, they don't actually know which type of doctor they want because they don't know exactly what are the scope of the need that they're going to need from them. And so you see regularly advanced companies with good funding where the CEO hires a quite junior doctor as a CMO position. And sometimes it's great because I think all of the regulatory is overseen by the regulatory office. All of the negotiation with key opinion leaders is done by another office, the CEO office usually. And what you need is only someone who understands well the pathology because you need certain support on designing your product. And that's the great choice. But if you don't know exactly where you sit and you need support and you think you're going to get it from anyone, and you therefore go for the cheapest option, that's when you're making a mistake. And that's when I've seen certain companies churning CMOs and be like, oh, we had that CMO for a year, and then we had that CMO for a year, and then we had that one for 2 years, and we're again looking for a CMO. And I'm like, how is that possible? How did you churn over in 4 years over 3 CMOs and you don't have a CMO currently when you're clearly patient facing? And you're like, well, it didn't work. And I'm like, it's not that that person did their job poorly. It's that your expectation of what the job was unclear. And that person had an unclear definition of what a CMO is. And it actually didn't work because it was unclear on both sides. And therefore it didn't gel. And you're like, they're not bad doctors. They're not bad CMOs. It was just completely mismanaged expectations and job description. So I've helped a couple of companies try to hire the right CMO and try to refine their thinking about how do you define a CMO, what the CMO will actually need to. It's an interesting process. It's another type of birth. You need to birth the CMO job description from the CEO.
Going back to your obs and gynae metaphors. It's really interesting. I think that clarity is so important. And clearly, it's a relatively nebulous role that we talked about. It can contain so many different things. It comes down to what the company needs. It comes down to the skills of the individual as well. And of course, they can go on to learn various things too. But you're right, aligning those things is very difficult because, like we said, no two CMO jobs are created equally. No two CMO individuals are created equally either. There's many variables in both sides of it. So actually, it sounds like that piece of work, with you coming in to go like, hey, look, let me just have a look at what you need. And then, hey, let me see who's around that could fit this. That's actually feels like that's what a recruiter should be. In a perfect world, that's an appropriate recruitment exercise, rather than just necessarily gatekeeping both sides. That's actually incredibly useful. My final question, Benjamin, is obviously you're involved in quite a lot of stuff. We talk about the sliding scale of CMO jobs there, and there's obviously a sliding scale of things that you can do. So you can do lots of things with different people. You said you're working with a fertility company, insurance company, AI company. You're a mentor on accelerators and all that sort of stuff. Do you want to just run through the things that you're up to and what's keeping you interested at the minute?
So I'm a mentor on a couple of accelerators. One is Learn to Innovate at the University of Exeter and Bristol. Nice. One is Byte Labs in London. It's two really good programs that have very different targets. One is for medical students. One is for junior doctors. And I try to support the cohorts of medics through nice. And better understanding of what health tech is and how to grow and how to understand health tech. I work with an insurance company called Juniper, which is a tech company, which is the first one to create an entire reproductive health cover for fertility, for pregnancy, and all of that. And so I help them design their risk models. They have actual actuaries that are designing the health models, and then I look at it with a clinical eye, and I just take a shotgun and put holes everywhere. I'm like, oh, this doesn't make any sense. Like for example, like you didn't factor in the cost of follow-up or the cost of that type of test. That leaves you with that level of liability, all of that, and that's a really, really fun job. I work with Bea Fertility, which is a medical device fertility company. I can see, Tess. It's an awesome space because they're just creating something completely new. Currently, fertility management is done at the clinic. There's no at-home care or very few at-home care. And they're creating a medical device where you could be able to do intracervical insemination at home. So you don't need the clinics, you don't need the nurse, you don't need all of that. And it's a really, really, it's almost creating a new segment in the fertility care. It's highly innovative. It's really, really nice. And it leads to incredible discussion. Like Tess what was it? It was last winter. Tess calls me and is like, oh, the FDA application, they want to rediscuss certain key metrics. And we spent an hour trying to figure out what the best proxy for sperm was. And I was like, okay, maybe we can try oil and cornstarch. And so I was like in my kitchen, putting like some oil and cornstarch, like throwing it on the wall and see how it sticks to see whether or not it would stick like sperm. And or I was like, oh, it doesn't work. Let's do agar. That's another jellifying matter. Let's try this. Like those kind of conversation, like it's an hour of fun. I'm like, this is just incredible. It's just perfect. Oh, and I'm doing a lot of things. I'm helping Imperial also spin out one of their companies. Oh, there's a company which doesn't exist just yet. They have an AI platform that measures and quantifies eczema and then provides the clinician with a support with regards to management and prescription. And so we're looking at how are we going to create the spin out for that company from Imperial. Tons and tons of different works, which, as I said, it's just I follow my heart, I follow my gut, and I have fun. That's what I do.
I love that. And you've done the work as well, is what I would say. Like you've read those documents, you know the legislation, you've learnt the clinical operations side, you know the financial models and where the pockets of money are. Like you've clearly gone through a career of learning this stuff, and now is a time where you're deploying it in areas that you choose. The way that you've set up your clinical life as well, like, locum consultant weekend nights allows you the full week to then exercise on everything else. It's like you've set everything up now in a way that I guess just allows you to live a life that you enjoy. And I think that's the opportunity that is available for people in health tech, but also for those people that hang on to the medicine. And I say hang on, you might really enjoy it and lean into the medicine. All power to you, wonderful. But I think you're a great example of that you don't have to choose one or the other. There are narratives out there that, to be in health tech, you have to start a company. That's nonsense. You can be part of a company. You don't have to start one. Therefore, you don't necessarily have to pick one or the other. You can keep both and excel in both like you are. I think it's a really interesting place in the middle where you are an expert of both. You are an expert of the clinical medicine to a consultant degree, and you are an expert in certain areas of what a chief medical officer can and should do, areas that include legislation, regulation, operations and clinical pathways, and you could list 100 of these different things, but you've chosen the ones that you want to become expert in, and now you're allowing yourself a life to deploy them exactly where you want to. I think it's just a really nice story, Benjamin. I'm like super pleased for you, man, that like you've set this life up, and I think any company that's going to hire you to be their chief medical officer is doing all right. Like, I think that's probably quite a good hire if they manage to get you. And I'm sure there's probably a few listening, to be honest, like in a like very genuine, authentic way. Like there's probably a lot of people listening that could really value either a project or a longer term arrangement from you. So I guess finally, before I let you go, like for those people that want to get in touch with you either to learn more, there's probably budding chief medical officers that want to learn from you. There's probably companies that can certainly use some of your time in various ways. Like, what's the best way for people to get in touch with you and to learn more?
I think the best way is just reach out to me on LinkedIn. It's the way that I get most of my discussions, professional discussions, is through LinkedIn. I'm not like you. I'm not a genius at presenting myself and doing in public, putting content. And
I think you were pretty good today, mate. And I'm no genius, but you were pretty good today.
That's nice of you. But yeah, I don't have a very content-driven LinkedIn. I just have my page, but that's where I do most of my conversation. So anyone can reach out to me on LinkedIn. I always answer.
Beautiful. Benjamin, it's been a pleasure. Thank you so much for coming on. I'm sure it won't be the last time. And yeah, we'll catch up soon. See you at the next event.